So my name is Doris Hansen from Moffit Cancer Center. Today I'll be discussing the pro-inflammatory state when peak cytokines are associated with toxicity and early response in patients receiving idecabtagene vicleucel. Idecabtagene was FDA approved in 2021 for patients with triple class exposed myeloma. Response rates, best response has been 73%, complete response approximately 33%, PFS about median 8.6 months. So in KARMA clinical trial that led to FDA approval, it was shown that a higher concentration of peak pro-inflammatory cytokines were associated with developing higher grade cytokine release syndrome. However, there has been no baseline association with cytokines and development of higher grade toxicity, so immune-mediated toxicities like CRS and neurologic toxicity, and no association with responses and cytokines, responses to Ide-Cel, that is. So cytokines are master regulators of the tumor microenvironment, as they represent the main communication bridge between tumor cells, tumor stroma, and the immune system. So the purpose of our study was to essentially examine the association between cytokines and the pre-CAR T bone marrow composition in patients receiving idecabtagene vicleucel, and to see how that affected toxicity and early efficacy or early responses. This is a retrospective analysis of patients treated at Moffit Cancer Center and consented to a biospecimen protocol. Cytokines were measured using the ELA immunoassay, and a pre-CAR T bone marrow biopsy was performed. We did a flow cytometry on a percent, or a subset of our patients, about 35% with samples available, and that was done to immune cell phenotype, T cells, myeloid cells, and natural killer cells. Our study cohort consisted of 86 patients. Generally, the patients had high-risk features, so like 1/3 of them had high-risk cytogenetics, nearly 1/3 had penta-refractory disease, and we also had about 30% of patients that had what we call a high plasma cell burden, which consisted of 50% or more plasma cells in the pre-CAR T bone marrow biopsy. Safety profile was similar to what was seen in KARMA. We did see that there was 3 patients that died of myeloma complications. Patients who were 65 or older were more likely to develop any grade toxicity, and those who had a poor ECOG performance status and required bridging were more likely to develop any grade ICANS. We did not see any secondary malignancies or T-cell lymphomas in this patient cohort. In addition, in terms of cytokines, so we did find some associations. So we found that higher peak concentrations of inflammatory cytokines, like the inflammatory panel that we analyzed, interleukin-2, interleukin-6, interleukin-15, tumor necrosis factor alpha, interferon gamma, were all, higher concentrations were associated with developing any grade cytokine release syndrome. In terms of grade 2 or more cytokine release syndrome, only higher peak concentration of interleukin-6 was associated with this. We did not identify any baseline associations with cytokines in developing higher grade CRS. However, this was similar to what was observed in KARMA. In terms of neurologic toxicity, we did identify some baseline associations. So patients who had a higher baseline or apheresis concentration of TNF alpha, those who had a higher D-6 concentration of interleukin-15, as well as angiopoietin 2-to-1 ratio of D-6, were more likely to develop neurologic toxicity. And those who had a higher peak concentration of interleukin-6, interleukin-15, and peak ratio of angiopoietin 2-to-1 were more likely to develop any grade neurologic toxicity. In terms of grade 2 or more neurologic toxicity, or ICANS, in this patient population, we found that higher peak concentrations of interleukin-15 and angiopoietin 2-to-1 were more likely to be associated with the grade 2 neurologic toxicity. Interleukin-15 is known to regulate T-cell effector function and has been shown to exacerbate neuroinflammation, cerebral edema. Angiopoietin 2-to-1 ratio is a marker of endothelial dysfunction, which may lead to permeability of the blood-brain barrier and potential disruption, increasing the risk for toxicity. We also, as I previously mentioned, were able to identify some association with response to idecabtagene vicleucel. We identified that higher peak concentrations of interleukin-2, granulocyte macrophage, colony-stimulating factor, tumor necrosis factor alpha, interferon gamma, were associated with developing a partial response or better, so essentially a response to idecabtagene vicleucel. This was also the case for best response and very similar for complete response or better. We also identified that serum cytokines are associated with plasma cell burden, so higher levels, so essentially indicating a high plasma cell burden is associated with systemic inflammation. And we identified that inflammatory markers like baseline ferritin is associated with developing neurologic toxicity and also is higher in patients with a high plasma cell burden. As I previously mentioned, in a subset of patients, about 30 of our patients, we were able to perform flow cytometry of the bone marrow aspirate, and we identified that patients who have a high plasma cell burden demonstrated markers of T-cell exhaustion as well as natural killer cell exhaustion, as evidenced by higher expression of CD39 among CD4 and CD8 T cells, as well as T-cell immunoglobulin protein domain, or TIGIT, among CD4 cells, and higher expression of CD56 dim natural killer cells, leading to impaired activation, proliferation, and upregulating expression of inhibitory receptors, ultimately favoring tumor tolerance. So in summary, if someone has a high plasma cell burden, that's associated with systemic inflammation, which in turn can lead to immune dysregulation and may impact T-cell function, fitness, and ultimately CAR-T product. So in conclusion, our study demonstrated that there is an association between cytokines, plasma cell burden, immune cell subsets, and inflammatory markers with toxicity and early response in patients receiving idecabtagene vicleucel. In addition to this, certainly our study provides some early insights into potential therapeutic optimization as well as toxicity prevention. Comprehensive analysis of the immune landscape, cytokine profiling are key factors to designing immunomodulation therapeutic approaches to really improve the efficacy of these novel immunotherapies. And certainly a larger diverse cohort with a longer follow-up is needed to truly understand the complex relationships of inflammation, immunity, toxicity, and response in patients receiving idecabtagene vicleucel. So yeah, that's a very broad question. So certainly, we already use inflammatory agents for patients who develop toxicity. The question is, now that we have some potential predictors, can we identify patients who may require prophylactic, for example, anti-inflammatory agents like tocilizumab or anakinra or even steroids? So that's the question. Can we do that, to reduce toxicity without impacting efficacy? Some studies in lymphoma have shown certainly you can reduce toxicity without impacting efficacy, but this has not been looked at in BCMA targets like idecabtagene vicleucel. So, that's one area of research. In terms of therapeutic optimization, there are, in the real world, we've done a lot of studies. So we have shown a few high-risk factors for patients who may have an inferior progression-free survival, in particular, patients who have high-risk cytogenetics or patients who have prior BCMA exposure. So the question is, how do we improve upon outcomes for these patients? Certainly, options could be combinatorial approaches, consolidation approaches. We've found that patients who have prior BCMA exposure tend to have inferior responses to CAR-T, and there was a signal for 6 months potentially. But that was not statistically significant. So it's still, sequencing of this agent is still a key question in this field. There has been, CAR-T2 cohort C that shows outcomes after prior BCMA are inferior as well. The real-world studies have shown the same. So I think, and now we have another target, talquetamab, which is, not BCMA. It's a GPRC5D. So I think, a lot of questions to be answered in the field regarding this. Moving forward. Another important topic is clearly patients who have a high tumor burden. They have systemic inflammation, they may have exhausted T cells, and they may not have as good outcomes. So how do we improve upon these patients? So clearly reduction of tumor burden is an important topic. So ideally, using effective bridging regimens or optimizing the bridging regimens to reduce tumor burden prior to CAR-T hopefully will improve toxicity and efficacy outcomes. In particular, it was shown in CARTITUDE that patients with high, studied by Cohen, that patients with high tumor burden may have increased risk for developing neurologic toxicity. So I think control of tumor burden pre-CAR T is also an efficacious and adequate bridging are some important topics in the field.